Welcome, everyone. My name is Monique Gignac. I'm a senior scientist and the scientific director at the Institute for Work and Health. Welcome to our IWH speaker series. Before I introduce our speaker today, Dr. Emile Tompa, I'd like to just run through a couple of housekeeping items. First of all, if you would like to access closed captioning, if you go to the bottom of the screen under the More button, you will find it there and you can turn that on. We will be making the presentation slides available. It may take a few days after the presentation, so you can look at them there. You don't have to take notes. You can just focus on listening if you like. In terms of questions, what we'll do is we'll wait for questions at the end of the presentation. Because we often get a lot of questions, some of them similar to one another, we typically ask that you write your question in the question and answer box. Again, you can find the Q&A at the bottom of the screen. We won't be using chat. If you have a question, we encourage you to ask them. Please type it in the Q&A box. Sometimes I am not able to get through all of the questions, depending on how many we have and how complex the answers are. So please consider sending your question directly to Emile at the end of the presentation, and he will have up his contact details there so that you can see them. And if questions are similar to one another, I try to kind of bundle them. So I may not be reading out the exact question that you've asked, but hopefully we'll get as much answered as we can. So that's just a little bit about how we'll roll out this presentation. Let me tell you a little bit about Dr. Emile Tompa. He is a senior scientist here at the Institute for Work and Health. He holds appointments in the Department of Economics at McMaster University and at the Dalla Lana School of Public Health at the University of Toronto. Emile's research interests include consequences of occupational health and safety system design on the health and well-being of individuals and populations, the economic evaluation of workplace interventions and the economic burden of adverse health conditions and disability, and the analysis of disability policy systems. Emile holds a 6-year funding envelope as a nominated principal applicant from the New Frontiers in Research Fund for a social innovation laboratory called Inclusive Design for Employment Access, or IDEA. This particular initiative is focused on skilling up employers to advance their abilities to tap into diverse talent pools with a focus on persons with disabilities. So that's a bit about Emile. Today, he's going to be talking about preventing PTSI, work disability at first responders organizations, field knowledge scan. So over to you, Emile. Thank you.
Thank you, Monique, for that introduction, and I'm delighted to have this opportunity to share with you part of a larger project. And I'll speak to that larger project at the front end, but really the deep dive will be on our field knowledge scan, which is the component of this project that I spearheaded. This project, as you can see, was funded by Alberta Supporting Psychological Health and First Responders Grant, so we're really honored to have had this opportunity to do this work for them. On this slide, I have listed our research team, quite a number of people from IWH, my colleagues at IWH, some colleagues also at the University of Alberta, University of Regina, and one of our colleagues from Wayfound Mental Health Group. And then a number of stakeholder partners are listed on this slide as well. So in terms of my presentation, I'm going to give you a bit of a backdrop just to get us going at the front end. I'll talk about the larger project goals and methods, and then I'll do that deep dive into the findings from our field knowledge scan, and then summarize that field knowledge scan. I'm also going to give a bit of an overview and a summary of a scoping review we did as part of another project, because it very much related to this area of inquiry. It was a project done for a standard that I was involved in, the CSA paramedic standard. So I will also touch on at the very end of the presentation a little bit about that standard. So in terms of project background, now this is maybe not new to all of you if you know much about this space. Occupational injuries are really quite common for first responders. When I use that vocabulary of first responders, I'm referring generally to paramedics, firefighters, and police officers. It's particularly a challenge for this group of workers in relation to both physical and psychological injuries. And particular issue that we're grappling with here in this study is post-traumatic stress injury. I'll use the acronym PTSI. Other terminologies used for this as well, such as occupational stress or OSI. Now, PTSI is a burden, obviously, for first responders, but not just for them, but their families, their workplaces, and society at large. Particularly an issue during the COVID time period and thereafter, when there was an inordinate amount of demands on their time, labor shortages, staffing shortages, and challenges just triaging all the demands for their time. Recent studies have shown that organizational policies and practices have very important impact on PTSI prevention. So our study is looking to see what can organizations do to better address PTSI prevention. The scientific evidence, unfortunately, is quite modest in terms of the better understanding the effectiveness of such programs. But regardless of the state of knowledge, it's really critical that first responder organizations develop ways to protect workers. And we're continually trying to add to that scientific evidence to help inform the way forward for the prevention of PTSI work disability in first responder organizations. So just stepping back to give a bit of a conceptual definition of PTSI, it's a non-clinical term that refers to the manifestation of a range of mental health injuries, such as operational stress. I mentioned that terminology already, operational stress injuries, clinically diagnosed post-traumatic stress disorder or PTSD, anxiety, and depression. The term refers to like valid psychological and physiological adaptations that develop when a person is exposed to potential traumatic events. And a terminology that we're quite familiar with is PTSD. It's a clinical term. It refers to a set of psychological symptoms experienced by an individual resulting from exposures to situations of actual or threatening nature that may be threatened death or serious injury or sexual violence and can cause significant functional impairments. Now, that's a definition from the American Psychological Association from 2013. But according to the Canadian Action Plan, public safety personnel have advocated for the use of PTSI instead of PTSD due to the stigma that is typically associated with clinically diagnosed PTSD. So from here on in, I'm going to use the terminology of PTSI. And in our paramedic standard, we use the term OSI. So I'll come back to that term as well. So in terms of the broad project overview and research question, we set out in this project to gather and synthesize evidence about PTSI work disability prevention from current practice, so field knowledge, and scientific evidence, peer-reviewed primarily. And the overarching research question that was driving our work is how can the evidence from both the literature and internationally based field experience in conjunction with some of the current practices of first responder organizations, particularly in Alberta, how can we take those three pieces of knowledge to be used to inform policies and practices for the prevention of PTSI work disability? So the model we use to guide this project is represented here in this diagram, the evidence-based practice approach, where we're taking practitioner expertise, best available research evidence, and stakeholder experiences to synthesize the knowledge base and better understand promising and best practices in the way forward in this space. I mentioned there was multiple components to this study. There's three modules to it. Stage one or module one was a field knowledge scan of international first responder organizations' policies and practices for the prevention of PTSI work disability. That's the piece I'm going to focus on in this presentation, but there are two other modules that are listed here as well. A summary of the scientific evidence, and then a third one, semi-structured interviews with occupational health and safety practitioners, managers, supervisors, and workers within Alberta first responder organizations. And that piece was to gather detailed information of the current practices for PTSI work disability prevention and the needs in the Alberta population. In terms of the field knowledge scan, so the research questions that were driving our scan was what are the organizational level programs, services, practices for primary, secondary, and tertiary prevention levels available and accessible for first responders? And then what are the contextual factors such as key actors, relevant processes, barriers, facilitators that have positive or negative impacts on the effectiveness of these PTSI programs, services, and practices? So that was the two questions that was driving the field knowledge data collection. And what we did was in-depth qualitative interviews with professionals and experts in emergency organizations around the world. They would focus on English-speaking jurisdictions. We did a scan of Canada, United States, United Kingdom, and Australia. And then once we gathered that field knowledge, we did inductive thematic analysis of these interviews to identify, actually, I think we have 10 themes that came from that field knowledge scan. So the key questions that we asked the informants that we spoke to are listed here. So we asked about what initiatives does your organization have in place related to the prevention and management of PTSI and related work disability. And we framed this quite broadly. This could be policies, programs, practices, either recently implemented or long-standing ones. And as we asked about these things and heard what these organizations were doing, we just probed a little bit deeper to better understand the various programs that they were working on to prevent PTSI work disability. The second question was, what is the effectiveness of these initiatives? And we tried to probe to better understand why they might be effective or not effective. And then we actually literally asked what makes the initiative effective or not effective. Then we went on to ask about, are there any other ideas that you would like to share about initiatives for the prevention and management of PTSI, work disability? And then we asked about gaps in supporting first responders in this space. And then any other ideas they wanted to share about unmet needs that they felt were really important for us to better understand and think about how we might address. So that was the probing, the questions we asked, along with a number of probes. Most of the interviews were about an hour. Some went a bit longer than that, sort of thing. So we spoke to key folks in organizations around the world. I listed them, US, Australia, UK, across Canada as well. So quite a rich set of data that we collected through this scan. And here we have just a representation of the sample of folks we spoke to in terms of where they're from and the types of organizations they represented. So in terms of firefighters, we spoke to 12 different organizations. Paramedics, we spoke to 11 different organizations. Police, we spoke to 8 different organizations. And the other category for organizations are a mix of organizations that covered multiple facets of these first responder kind of services. And in total, we had 35 key informants that we spoke to across Canada and internationally, as well as a few specifically in Alberta. And then we undertook inductive thematic analysis, where we came up with 10 themes from these interviews. And I'll go through them over the next few slides. The first theme that arose was about specialized programs and services. We heard a lot about the need to recognize the very unique experiences of first responders. Multiple programs had been developed specifically for this population. And a number of times people spoke about how generic programs, such as EAP or EFAP, employee assistance program, employee assistance and family programs, not being very effective, even though they provide the kinds of services you might think would be useful for people who have mental health challenges from workplace exposures or elsewhere. They just found that they didn't have that understanding of the particular unique characteristics of this population. So it was very, very critical to have specialized programs designed exclusively for this population. Common, as you might imagine, is this stigma associated with mental health. Mental health, particularly in this population, it was mentioned quite often about the sense that folks felt that they need to be tough, they had to be heroes. We're having macho images, often male-dominated industry or sector, and so often it was mentioned that this became a very major barrier for support seeking at the individual level, and also the stigma associated with even being openly speaking about mental health issues in general. So this was a really, really important challenge, because expressing feelings, acknowledging needs for support was just not commonplace with many of these people. Really critical concern related to that then is the need for confidentiality or anonymity. There was often commentary about the lack of trust of in-house services. If thus the mental health services are provided in-house, that concerns that it may affect their career advancement opportunities. Obviously, this relates to the second theme that I mentioned. And also, there's another theme that will come up within the next slide, which is about addressing multiple pathways for support seeking. And that was often mentioned as a way to kind of address the desire to have that confidentiality by having the services offsite, unrelated to the organization itself, so that the person could seek supports through these other avenues. Right? I'll get to that in a little bit more detail when we get to number 7. Training was mentioned a lot. So it may be commonplace to have onboarding programs, sometimes screening and training to make sure people have that resilience. R2MR is one of the programs that are often provided at the front end. But it was mentioned that training is really critical at all levels of the organization and on an ongoing basis, including leaders of the organization as well, so that everybody's up to speed of how to address these issues, how to be sensitive to them, how to provide peer-to-peer support, and being sure that everybody was up to speed on what their role is in ensuring the organization has the ability to address people's needs as they arise. Refresher courses and workshops were mentioned a lot as being good ways of making sure it's always top of mind. Courses on mental health, nutrition, exercise. I'll speak a little bit more about some of these other non-traditional kind of courses that were spoken about a lot, that goes beyond just thinking about mental health, but thinking about what we'd sometimes describe as the whole person approach, thinking about health and well-being overall. Training for spouses was also mentioned, and for family members to better understand and provide support as well. So it goes beyond just the organizational actors into the community, into the family units. A fifth theme was communications, really being sure that everybody is aware of the supports that are available and the different avenues of support seeking, so that the need arises, there isn't any challenges of figuring out how do I navigate the support system. Information sessions on mental health and nutrition and exercise, as I mentioned as well, is a really critical place where you can maybe sometimes describe the different avenues of support seeking and paths of supports that are available within the organization and beyond the organization. There was mention of posters to encourage being mindful of own mental health or and peer support, and the availability of supports that may be available within and beyond the organization. I mentioned the whole person approach. That came up in a few really innovative programs that were offered I think, in the US and the UK as well. We heard about taking a kind of a total worker health approach. That's a terminology from NIOSH in the US, but has lots of counterparts to this notion of the whole person. So thinking about not just mental health, but nutrition, exercise, work-life balance, wellness in general, in addition to the mental health needs, because that strength and resilience comes from having just, full health and well-being in terms of, having that resilience across all facets of your health and well-being, to ensure that you have that, resilience and foundational strength to deal with issues as they arise. Family health and well-being needs were also mentioned as really critical. So it's not just about the worker, but making sure the family has those resources and learnings available to them. And then community building as well, to build some social cohesion within the first responder family organizations and in their communities as well, through group events, barbecues, community gatherings, maybe some sports events and things like that, to really help build that sense of social cohesion in the first responder communities. The seventh theme was about multiple avenues support seeking. I gave a little bit of background about that. Really critical, have people be able to choose the pathways they go to seek for support, whether it's within the organization or if they feel uncomfortable about that, to have some support available outside of the organization as well. Sometimes it's offered through labor unions that are associated with those first responder organizations, or in the broader, community of supports. But really critical to have those options, so that a person, when they have those needs, can seek the pathway that they feel most comfortable with. An eighth theme was the importance of having a continuity of services. Really, they need to be available across the employment journey, not just at the front end onboarding, but also maintenance during absences from work, and in the return to work process, and also throughout the career. Um, Even when thinking about when people exit to retirement or other activities, that there may still be some residual traumas that surface after you left, your occupation as a first responder, so that having it available for these folks throughout their lives is absolutely critical for to do a full just job of providing the supports people need when those needs arise. The continuum of support should obviously be considering both primary, secondary, as well as tertiary prevention interventions. And again, as I mentioned, that whole person approach, including family and community. Research was mentioned a lot, actually, which I'm pleased to hear it, that people thinking about wanting to have a strong evidence base to support an understanding of what works well and what doesn't, or what kinds of contexts things work well in. Um, there was talk about in-house assessments through surveys and audits, monitoring and evaluation as well. So in-house assessments would help inform what's working well or what's not and what needs to be tweaked. Many key informants also spoke about ties to academics and importance of rigorous research evidence to support their understanding of best practices. So evidence emphasis were given on evidence-informed programs and services and practices. And they noted the need for continual improvement approaches through ongoing assessment and scanning and research, so that it's not about just figuring out what you need, setting up those programs, and then it's a done deal. The environment changes, needs change, the labor force changes, and there's always need to revisit things to make sure they're still working well. And if not, why not? What else do we need to do to make it work better? There was often comments about resource constraints noted by almost everyone we spoke to, and it can take different forms. People time constraints due to extensive demand, so that they just don't have time to seek the services sometimes, particularly during the COVID pandemic, where little time was available to decompress because there was so much demands on their time. Funding cuts came up a lot, and that resulted both in staff shortages, but also made it difficult to provide a full suite of support services. And then smaller and regional services in particular, where sometimes first responders or volunteers were particularly constrained. And then sometimes there just wasn't the availability of the services in some regions, and that became an issue as well, is that just where do you go to find these services unless it's offered remotely, and some things just don't work that way. You really we're stuck to where do you find those services in some very remote communities. So that's the 10 themes. I will just summarize then the promising practices that we heard about from this scan. So the focus on total worker health, absolutely critical, including the family and across the employment journey. um, Leadership training to improve how to care for employees. So everybody has to be up to speed, and supporting the process, in particularly leadership. Culture comes from top down, so leadership has to have buy-in and knowledge and support the process. The top-down support, championing worker health and well-being, really critical. Relationship building across the organization. I talked about social cohesion, but also beyond the organization as well. And then diversity and inclusion initiatives to ensure everybody feels welcome. So try to get past that macho male dominated culture to think about the diversity of people's needs and social locations, so that everybody feels they belong. And then conducting research to determine best practices and support continual improvement, really, really critical. And then I hear last item here I have is just a Royal Foundation from the UK, 6 voluntary standards that were mentioned by some of the folks we spoke to in the UK. Prioritizing mental health in the workplace and developing those programs, ensuring work design and organizational culture to drive mental health, promoting open culture around mental health, increase organizational competences and capabilities, providing the tools and supports, and then in transparency and accountability through internal and external reporting. So that those 6 points pretty well summarize what we heard from people we spoke to in this scan. And then just summarizing some of the barriers and challenges we heard about. And I've touched on these already quite a bit, but I'll just summarize them here. Culture, where seeking support was considered a weakness or a barrier to performance. Lack of trust and confidence in the management, particularly use of in-house services, concerns about potential short and long-term impacts on one's career. Obviously, that's related to that trust issue. And then service providers not having the knowledge of first responder experiences. So really having those customized supports based on a deep understanding of the unique situations of first responders. Programs not being customized to the context of first responder experiences are really important to think about how we can get past that and really think about customized services. Lack of funding, lack of service availability in some regions, lack of leadership and buy-in, long shift hours and long commutes that sometimes restricted ability to seek supports, and then lack of quantified measures of overall effectiveness of programs, and then gaps between research and its translation into evidence-informed decision making. So that summarizes what we heard from this the first module of that study of the knowledge, field knowledge. Now I'm going to change to another study for a couple of slides, just giving you a high-level summary of a scoping review that we did as input to a paramedic standard that I was involved in, and this was the research component of this of that informed the standard. And the last few slides I'll talk a little bit about the standard as well. So in this scoping review, we looked at academic online databases to identify 50 studies. It included studies of Army personnel, police, firefighters, paramedics, Navy, and mixed populations, categorizing PTSI program services into, we categorized the PTSI programs and services in this study when we synthesized the knowledge base into 4 categories, looking at individual programs, peer programs, supervisory programs, population-directed interventions, right? So they're listed here. You see those 4 categories: individual directed, peer directed, supervisory directed, and population directed. And I'll drill down a little bit more on what we found related to these 4 different categories. So for cluster 1, individual directed interventions, we saw a cluster of programs that were offered for emotional self-regulation. So training interventions aimed to change emotional responses of individuals. It was often a mix of psychoeducational directed exercises, mental focus and awareness, and cognitive behavioral therapy, mediation, self-practice, and mobile games. And I have a list of examples of programs that we came across in this literature that fit into this category of emotional self-regulation. Another cluster is on cognitive self-regulation, so training interventions aimed to change the cognitive responses of individuals. It was a mix of stress response, psychoeducation, exercise in strengths, adaptive coping strategies, self-efficacy, social support, and self-reflection. And again, a list of examples of programs we saw reviewed, evaluated, elaborated upon in this literature related to cognitive self-regulation. Cluster two was about peer-directed interventions. So peer trauma risk management training for early identification of high-risk individuals and group sessions to undertake cognitive and emotional responses to exposures. Some educational sessions that increase peers' awareness of symptomology and treatment for mental health conditions, really enhancing ability to support others and practice in facilitating supportive conversations. And again, a list of examples of programs that fit into this cluster. The third cluster was for supervisors to interventions directed at helping them get up to speed on how they can provide support. So these are supervisor directed training interventions through education, including a mix of psychoeducation, workplace mental health risks, supervisory roles and responsibilities, and communication skills. It's very similar to that peer training interventions, to increase their ability to recognize symptomology and mental health conditions, ability to support subordinates experiencing these challenges and facilitating supportive conversations, just increasing their awareness of mental health risks specific to the workplace and the occupation, and the awareness of responsibilities that they have for creating a supportive work environment. And a couple of programs we saw in this category, one of them Respect, another one was called Head Coach. And then the fourth cluster is population directed interventions. This is a mix of the other 3 basically, right? So population directed multi-component interventions really combine the individual education, peer and supervisory directed early interventions and crisis management resources, as well as organizational directed new administrative units to really get all facets of the organizations and the people in it, the workplace stakeholders, up to speed on the relevant issues. And a key example of this kind of program is Together for Life. And now I'm going to turn to, in the last few minutes, the standard that I was involved in, that piece of scoping review literature that we synthesized really helped inform. It's a standard that was released in 2022, Z1011.1. It's called Work Disability Management in Paramedic Service Organizations. Now, this standard applies to the requirements for a work disability management system, which can be used in paramedic service organizations to address the health needs of workers to prevent and/or manage work disability. So it's broadly scoped but has a deep dive into what here we use the vocabulary of occupational stress injury. So it includes the specific requirements and guidance related to the management of disability associated with occupational stress injuries and other mental health conditions that can be due to work-related exposure or even non-work related exposures. And then it includes a general framework that applies to any type of disability. And it takes a management systems framework, which really thinks about all facets of the organizations and all roles and responsibilities across the organizations, rather than thinking of as it being the responsibility of a particular person or a particular department. It really is a management system that weaves into all facets of an organization. And it's really framed around the notion of continual improvement. I mentioned that vocabulary earlier on. Continual improvement is the concept that you can always do better, and you need to revisit these issues to make sure that what the organization is currently doing is meeting the needs of its workforce. And so on a periodic basis, you revisit and review and assess where there's room for improvement. And it's often associated with the notion of Plan, Do, Check, Act, or PTCA. So I'll give you a bit of an overview of what's inside the standard. And here's a picture of the front cover of the document. The first core module, clause 4, identifies the roles and responsibilities of the key stakeholders. So there is detailing of what the roles and responsibilities are of top management, frontline managers and supervisors, internal subject matter experts, disability management specialists, healthcare professionals, and workers and their representatives, unions in the paramedic community. The three clauses that focus on the PDCAA, Plan, Do, Check, Act, continual improvement process are clause 5, 6, and 7. So in clause 5, it sets the stage, the plan, where you do reviews, you identify gaps, you make a plan to reach some objectives in this cycle, and then you commit to the continual improvement process because you know that this is just one of ongoing cycles that you'll be doing. Clause 6 gives some guidance on how you implement that plan. Thinking about person's needs, organizational needs that need to be addressed, and then prevention and protection measures. And then clause 7 is about performance monitoring, evaluation, and continual improvement. Measurement and evaluation are critical, both process and outcome measures. So you want to make sure you're on the right path to reaching your targets and that the outcomes are being achieved that you had set for in your plan. Making sure it's scalable to size as well for the organization's needs. Using both qualitative and quantitative methods to do that assessment. And checklists and audit tools that help support better understanding how well you're doing it, where there's gaps that still need to be addressed. And then there's a number of annexes to help support the process as well. So Annex A is about wellness checks during a medical leave. Annex B about mental health literacy, training, and education. Annex C is about workforce exposure programs, and then provide a bibliography with references to where you can find additional information. And here is a very microprint list of various publications and presentations related to the core project study that I've been speaking to here today. And then we're going to open it up now, I think, as to questions and comments, just acknowledging again the funder, the Institute, and then my coordinates if you want to reach out to me afterwards.
Okay, thank you very much, Emile. That was a lot of information, really interesting and great information. We do have some questions. If you would like to ask a question or make a comment, please use the Q&A box at the bottom of the screen, and we'll get started and begin asking you with some of this information. So first of all, Emile, I have a question from someone who's interested in thinks very interesting work. For the environmental scan, did you find differences in perspectives across the different sectors? Unique or very similar issues, for example, across police, fire, paramedics?
Good. That's a really good question. Yes, there was unique situations that were sometimes by the type of first responder. Sometimes it was about the jurisdiction as well. The size of the entity, the country as well. So the UK, we heard very interesting things in the UK that were very different from the USA, and in Canada as well. So I think that message came out really clear in the work we were doing, is that the context is really important to understand for effective service provision, right? So yes, there's unique things for different types of paramedics, but that's not the only thing that makes them distinct. There are
Do you
also
do you
other
have a couple
aspects.
of little examples that you could give us of some of the ways that either countries or the issues differ? Just a
Okay.
couple of tidbits?
Yeah, for sure. I remember in the UK we were talking to a paramedic organization, person who specialized in providing the services for addressing their PTSI needs. And it was very centralized, and the challenges that this person we were speaking to, it was they had just gotten through we had gotten through the bulk of the COVID pandemic issues, and the biggest challenges was the trauma that even the person themselves was experiencing, of having to triage things, because there had been funding cuts, and so there was not enough people time, and then the demands on their time and the trauma that they were experiencing, and they had to decide what services to provide and what services they just couldn't provide. That was trauma in and of itself, let alone just experiencing traumatic events as a first responder, was just having to deal with the workload issues. And that was multi-layered, as I mentioned. Had been funding cuts, and they were trying to centralize services, I guess, and probably thinking about efficiencies that probably didn't get realized, and they got even more challenging for them. That was a very unique situation for them, right? Not
Okay.
something we would hear about, say, in the US.
Right. So that leads to maybe something that's a bit related. Someone is wondering whether you spoke with or whether there were programs that you heard about for people who, for example, aren't maybe the first responders, but things like people like the support staff. And they give an example of support staff that work in our CMP offices that are viewing all the files and potentially becoming triggered as a result of seeing documentation and photos of crime scenes. Did you hear about those programs? Are there people you spoke with about those issues?
Yes, yes. Yeah, a very good point. And I'm glad this is being mentioned, because we don't want to shortchange the fact that all of the folks working in these organizations experience challenges, trauma, because of the type of work that they do. As the example I gave with the UK organization, the person actually delivering the services was traumatized just by the fact that she had to make decisions on what they could do and what they couldn't do, given resource constraints and time constraints. That, or so, so wherever you are in the service delivery of paramedic services, for firefighter services, or police services, you will be exposed to some of these kinds of issues, and the service provision um, provided in these organizations need to think about all the actors in the workplace, not just the frontline folks. Certainly, they are
Mhm.
the ones that sometimes will experience the traumatic events firsthand, but the others also are party to it, oftentimes in different ways, and will also have the need for these kinds of services. So the one way when I speak about the battery kind of packages that need to be made available and customized for unique needs of different organizations, it's not just the first responders, but all the folks in those organizations.
Okay, thank you. You spoke a bit about some of the kind of stereotypical male cultural values and the stigma that can happen with,
Mm.
seeking support, receiving support. So you've got all these programs that you've mentioned. But then it seems like there's potentially this barrier of people just not even going to get them, or men, some men who need them really not being willing to access them. Did people talk about strategies they use to help get over that initial barrier and get more men into some of these programs, or others who were concerned about support?
Okay, that's a good question. Yeah. So we did hear a lot about that, as I mentioned, and particularly if it was an older population, cultural norms are changing over time, as we all know. There's much more of a comfort level nowadays with a younger cohorts about speaking about mental health. So it was often in communities where it was in older communities, and there was still that traditional notion of this being a culture of being a hero, being resilient, being strong. You're providing the support rather than needing the support. So in those organizations there was really a strong emphasis from what we heard for supervisors and managers being up to speed on helping get past some of those barriers. Sometimes having the social cohesion of the community events, the barbecues, whatever, create a camaraderie that would help support the process. Very common also done in this space is debriefings after traumatic events as well. So there's a firsthand opportunity to try to address some of those issues right after a traumatic event has been experienced by a crew, that kind of thing. So it usually multi-pronged, but I think the important part is the role of leadership and people managers to be up to speed and trying different ways of helping break down some of those barriers.
Hmm. And it's a bit different, but it may also be somewhat related. You talked about peer support programs,
Yes.
that there are a number of peer support, but also you talked about concerns some people have about privacy, that they don't
Mm.
want
Yeah,
others to know they're
yeah,
in a
yeah, yeah,
program or
yeah,
recognize them. Did anybody put those two things together? And, is that a challenge of peer support programs
yeah, yeah,
that I may not want you
yeah.
to know that
Yes,
I'm
yeah.
dealing with a problem?
Good point. Very good point. There might, at the face value, maybe see some contradiction there, but the confidentiality and privacy issues particularly came to the fore about supervisors and managers. And the HR process, that you're concerned that this is going to be on your file and be tarnish your opportunities for career advancement. Whereas peer support can often be informal, and a lot of these programs, help people understand how they can be supportive, even if the person doesn't open up expressly about that their need to seek support, but you see that they're struggling, that they need to kind of decompress or whatever they might talk about. So the peer support is really your colleagues, your coworkers, being in tune with these issues so that they can be there and to talk about issues, whether directly or indirectly through and informally to help support, building the sense of camaraderie and that you're caring about your coworkers and their situations, right? So I the confidentiality and privacy issues were more within the kind of the hierarchy of supervisory managers and HR people, folks who might then know this person maybe had some challenges last year, the year before, and might not, but will inappropriately think that this person is not the best person to be advanced to a supervisory or managerial position, that kind of thing. So it was really about the career part that was the privacy, particularly important for folks that we spoke to.
Okay, thank you, because that relates to another question, and I think you've mostly addressed it. An individual was asking about in-house mental health practitioners, like psychologists, that they consider it a good model to have
Yeah,
these people
yeah,
in-house that you can consult, but they were wondering if there are confidentiality concerns,
yeah.
perhaps, with that group.
There was, and it's not uncommon for some of the larger programs that people we spoke to that had in-house services available as an option, right? But they also mentioned that it's important to have outside services also available for the people who don't want to take the risk of you going to in-house services. You don't want people to go without the support that they need just because of psychological barriers about think concerns about careers and your identity, I guess, with your colleagues, right? So having multiple avenues of support seeking was mentioned by many folks, so that people have choose the path that works for them.
Right. Okay. Thank you. What sorts of preventive measures like training, education, et cetera, would you recommend be mandatory in these high risk kinds of professions or workplaces? Are there any things
Okay.
that kind of,
Yeah.
I mean, you recommend or studies
Yeah.
that
Yeah.
recommend
Yeah.
that kind of
Okay.
came up?
Yeah, I'm kind of reticent to make strong recommendations for any one program because, as I mentioned, the literature's new and there's modest evidence on the effectiveness of these programs. One still needs to do something. I really emphasize that at the front end. Like for this is not suggesting that first responders wait to get stronger evidence. No, you have to act on it. So that's why I'm throwing out there a lot of different programs that have been written about, tried in the field. We found in the literature as well, but we didn't do a synthesis of the effectiveness of any one study. So I would think, I mean, you look to see which ones you currently have in place, where there's gaps through that kind of scanning process you do in the plan, do, check, act thing, and think about what options are available and which ones meet your needs. It is a customized approach at the end of the day too, and there are lots of different possibilities. You can't do them all, but you have to pick and choose of the ones that are out there and have a bit of background understanding of how they might meet the needs of your particular constituency. But I wouldn't recommend a particular program at this stage. And
Okay.
and
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 that,
one program doesn't, like I said, it's customized. One size doesn't fit all.
right. So that does speak to a number of the questions where people are asking about effectiveness. So at this point in time, that we don't have a lot of studies like that. Are there some countries that are a bit further along in looking at
Yeah, yeah.
effectiveness?
There is a lot of work being done in this space. It's at the early stage of just intelligence gathering, finding out what's happening in the fields and what they're doing, getting just some field understanding of what, at least at face value, they think is working well or not working well for them, and why, so that we can start to think about how can we do more rigorous assessments of effectiveness and understanding the context under which they work well or don't work well in a an academic kind of framework that helps really build a strong, solid evidence base that we can then also get into peer review, but also use that to inform the way forward. I think that's in the works going forward. And many people mention the desire to build up that evidence base, right? So they're very cognizant of the fact that even when they are doing things, they're not 100% sure that this is the most effective way to do it, then that there's a desire out there to help build up the knowledge. I was really surprised at how willing people were to speak to us, even during, but some of this was done during COVID, um, because they felt that the knowledge base needed to be built up, and they wanted people to come into this field like us doing this research project to build up that knowledge base, because they really valued evidence-informed policy decision making or evidence-informed best practices.
So I know this is being built up, but we have some questions. And so maybe rather than, I think you will say we don't have
Mm,
the evidence, but in terms of doing evaluations,
mm.
looking at effectiveness studies, has it been your experience of what you're seeing here? Is it typically that people kind of look at the whole program and evaluate it, or do they sometimes break the program down? So, for example, someone is interested in the debriefing component and whether psychological debriefing is an effective strategy. But it seems like a lot of the time these are all thrown into a much larger program with different components, and they don't pull out the different aspects of it.
Yeah.
Am I wrong? Is that correct? Do we know something about things like
Yeah.
debriefing?
Yes, a good question. It is a complex environment, and there's many things happening at any one time in any organization, but in particular in this space where we talk about primary, secondary, and tertiary prevention initiatives, and many organizations have multiple avenues of support seeking, and have been constantly scanning the environment to see how they can do better. So they're making tweaks at the end, at the margin, sometimes with some of these programs. So deconstructing and undertaking a rigorous evaluation of components or whole programs is a challenge, and certainly, but we need to confront that challenge going forward. And I think building up, some way of doing through maybe changes in environments in different contexts to see how different environments can make a difference for types of programs or how it's deployed. There's many different aspects of a program, maybe not just what's in the program, but the context, how it's deployed, the process type stuff, as well as the outcome stuff that you want to look at. I do think that is the agenda going forward, and sometimes the components were important to kind of drill down on to understand what components are working well and which are not. But then you want to think about the mix of programs as well that make a difference, because some of them may complement each other, some of them leave gaps, right? If you don't have a full complement of program. So I do think the evaluation need to be done at different levels, components, programs, initiatives.
Okay. All right. Thank you. Aside from Australia, do any other countries, states, or provinces have regulations? So regulations on psychological safety in the workplace. And are there enforcement challenges that are commonly encountered in implementing these kinds of regulations?
Okay. That's a good question, but I actually don't know, and I should look it up. It's very interesting what the regulatory framework is for particularly around PTSI and related work disability service requirements. What is the obligations versus the things that are done voluntarily, and I'm not 100% sure about how that varies across jurisdictions.
Okay. Um, just we have some quite specific questions that I may not be able to get to because we only have
Mm,
a couple more
sure.
minutes. So I just wanted to say I would encourage people to reach out to Emile and ask for these specific questions. There are some about accessing different programs
Mm.
and some differences between very specific programs. And so please do reach out to Emile. But someone is interested in some more information about the diversity of the people that you spoke with
Mhm.
in the study. And I know you did a lot of in-depth interviews in those initial interviews. So, for example, did you speak to wildland firefighters as opposed to urban firefighters? And can you just talk about how you captured some of that diversity that the different occupations would have confronted in terms of their location?
Good question, because there was a lot of diversity. So it's a really good point that they're asking, and I keep emphasizing that the context can make a difference. There was quite a bit, like with folks in Australia. Some of them were rural firefighters in Alberta, some regional voluntary firefighter organizations as well. Talked to I think it was one of the bigger urban police force services as well in the U.S. We spoke to paramedic services in the UK. So there was quite a bit of diversity there in terms of geographies, the size, the context, the services, and the funding. And we kept probing about that because we realized that that's going to be a really critical aspect of this when they talked about the kinds of programs they had in place, and what they thought is working well and what wasn't working well, and what were some of the barriers to effectiveness. We gathered a lot of rich information that way to better understand the contextual stuff that make a difference. And in our 10 themes, we try to emphasize the things to think about in terms of the context and the variables that come into play. It does make a big difference. And I've listed maybe some of them, or probably not all of them, certainly the type of first responder, the geography, the resources, the actual workforce. As I mentioned, some of them were older workforces, particularly rural communities, volunteer kind of thing, totally male dominated, traditional values, that kind of thing. So that's going to be a whole other ballgame compared to an urban, younger, well-resourced group kind of thing. So context makes a big difference, and that's why. our findings here. And I think the standard that I pointed people to as well really emphasizes doing your in-house homework, in terms of evaluating kind of the lay of the land, doing your scan to understand what the needs are of your workforce, and what the gaps or challenges are for that group so that you can customize those services.
Okay, thank you. We probably have time for just one more question, and it's a big one. So
Mm,
just to kind of
good.
putting it all together, and that is, you outlined different themes, and
Mhm,
then you talked about some of the work with different kinds of practices that
mhm.
are out there, interventions, and the standard. Sort of taking a look at all of this, do you have a sense of what some of the best practices might be for interventions in this area? Do those themes represent components of best practices? Anything that you would um, kind of say related to setting that up
Yeah, that is a big question. Okay. Well, I've been using the
in two
vocabulary.
minutes?
Yeah, okay. Okay. Well, I've been using, as you probably noted, promising practices, right? Rather than best practice. Best practices suggest, to me at least, that they've been rigorously evaluated, but I'm promising that what we heard in the field from at least my component of this study, the field knowledge, was that this seemed to be working well, right? Or these are the issues, right? And the most important thing, as I think I mentioned at the front end, was the customized understanding of people's needs in this particular sector, that it cannot be generic programs off the shelf stuff you purchase from a service provider like EAP programs that across the board didn't work. So I think that was a really resounding commentary that we heard about, that you think about your particular workforce and their unique needs and get expertise that is deeply familiar with that population. And maybe even familiar with the general context of your organization. If it's somebody that's in a rural setting, the service provider has to understand where they're coming from. They're voluntary service providers and they have other jobs or whatever. So the customization was really critical. The deep knowledge was really critical. And then the other thing was just the mix of services across your work lifespan, but also the diversity of options for pathway. It was support seeking was something we heard a lot about as well. So I think the comprehensive package and options, I think was it. Maybe I'll leave it at that for now. The two important
Okay.
things to think
All
about.
right. But thank you very much. It's been really fascinating. And I am for our listeners, again, the slides will be available. And I
Mm,
know, Emile, that you and the team are working on reports and manuscripts that also will be
yeah,
available on the
yeah, yeah,
IWH
yeah.
website. So please do check in for that. I want to again thank you so very much for this talk and to all the people who joined us today.
Mm,
To listen. Please, if I apologize again, if I didn't get to
mm,
your question, please reach out to Emile.
yeah. Okay,
And
cool.
I guess just to wrap up here, we're going to take a little break over the summer. So this is our last presentation in our IWH speaker series for the spring. And then we will be back in September. So I hope you will join us. Look for news that comes out from the IWH regularly. And thank you to everyone, including you, Emile, for
Mm,
today.
okay, thank you. Bye
Thank
bye.
you.